Are the skin, and really how you describe that, don't, and she's right, the number one thing is not applying heat, because essentially that irradiated area is like a sunburn, a bad sunburn. If you add extra heat, can you actually cause a break in the skin, which we do not want. The goal is to maintain the integrity of that skin, so they don't get an infection on top of the irradiated skin. So meticulous skincare, no heat.
What about aloe vera?
Oh, that I don't know.
Because you would think, like...
I don't know. I can tell you that we would not use that in the hospital.
Yeah.
Yeah.
I was
so,
just guessing.
I don't know. Good question. Hello, Julie.
I don't know how long my brain is working.
Oh, this is wonderful. Now you can let me know go search for orientation.
How can you tell? It would be like red.
Okay, red.
There's I'm just going off the top of
Your
my
review.
head. Your review, but
Fever? Yep. What about your white count?
it's gonna be elevated.
Now, post-surgically, do you have a normally slightly elevated white count?
Oh, yeah.
Yeah, that tells you that your immune system is working fine. But when it gets to a certain level,
It's,
I don't know, around 12,000 or something. Yeah, so you know that it's trending up, it should not. So
Yeah.
post-surgically, it's gonna maintain, post-op day one usually, then after post-op day one, you're gonna see that white count usually go down.
okay.
Post-op day two, it might push a little bit, but when you start seeing it trend up, you have an issue. Okay, so how else can you tell?
But well, the site, you know, the site,
What's the site gonna look like?
if it's like red and flames,
Red and green?
it's gonna be, it may have like the, like, skin is infected.
What kind of drainage is that that's plus? Purulent,
Yeah,
right?
drainage.
Definitely not clear.
You can sometimes smell.
Yep. Talked about that this morning. Stinky. Stinky,
Yeah.
white, cloudy, and then could it go green, yellow? That's not good. Because what does normal drainage over the course of a couple days look like? So, sanguineous, saying is red. So red, little bit, not excessive. And then where does it go from there? Sero. And what does sero mean? It's clear, either pink or yellow. Which one's further out? Yellow serous. And what that means, that serous drainage should be clear. If it has any cloudiness, you have an issue. It may not be stinky at that point, but it will eventually. And then, of course, no green. So if they go home with serous drainage, just a little bit, you're looking good. But if it's still sero or sanguineous or serosang, yeah, it depends on how much it is. It's going to depend on if they get to go home. That could be a variable. So anything yellow, green, or purulent is not good. You have to get a set of vital signs. And then they're not gonna order, you're gonna be getting the heat culture, wound culture, get it in there, really dig in there. Now, could this wound infection cause some dehiscence? Yes, because of the drainage. You could actually see a little bit of splitting with that. So we're going to make sure that we assess that wound, look at the drainage. But what if it just splits and just has normal movement dehiscence? What do you think a nursing intervention? I would call it up and say there's a corner here that's kind of starting to pull. It could be in the middle or whatever. So is there something that you could actually do? Well, what you need to do is you need to approximate those edges. So, and then you need to use a steri strip to pull it over and then tape it to the other side, right? But make sure when you do that, you get it perfectly straight. Does that make sense? In other words, like this side, you don't want it up, you want to get it in perfect anatomic alignment, approximate those edges, pull them together. So it takes a little bit of effort to get that really close, and then put your, just push your tape down on the other side with the steri-strip. That's what the doctor will tell you to do. So if they have already some steri-strips, you might just need a couple of extra. I don't think the doc's gonna go in there. I've never seen them come in suture, just because they have a slight dehiscence. But really the major thing is assess for infection. Because what if you miss that? It could be bad. Are you kidding? If you ever worked on a general surgical unit, some of the worst post-surgical complications are abscesses in here, and especially with elderly folks. Did I say elderly? Obese. If they have a huge gut, right here, a lot of subcutaneous fat, those are the ones that typically have the abscesses. With the big old Penrose drains, it's not a pretty sight. And oftentimes the organisms are resistant. It's an ugly, ugly thing. They'll be on antibiotics, it's like osteomyelitis, like every 4 hours. So yeah, recognize signs and symptoms of infection, not only because of that, because they could die from sepsis. That's where my acute brain goes. Yeah, okay, you guys are doing great. So far, so good. All right. We have, what do we have here? Oh yeah, we're just doing the full review today. Yeah, they're gonna have some lights. Yeah, for sure. Oh, let's see. Okay, so this is step 2 hour, all of these. So some of the post-op complications are blood clots, atelectasis, pneumonia, shock, and many others. Some of the most life-threatening, oh yeah, this is our intervention thing. So, let's talk about interventions. Can any of these kill a patient? Can that kill a patient? Especially elderly, UTI, how about urosepsis? Yes? How about thrombus? Of course, yeah. Could end up in the brain, the heart, or the lung. Small bowel obstruction, can you get an ischemic bowel from that? You betcha. Infection, sepsis, hemorrhage, hypovolemic shock. Dehiscence could be infection. We can probably put evisceration that needs to be taken care of. The docs are the ones that's going to put that back and probably do a sew-up job. All of these can kill a patient. Now, guess what? We're going to talk about interventions. So let's move on to Donna. What are your major interventions? I'm going to have to close out of here and go back in, but I have it in my head. So what are your major interventions to prevent all this stuff?
Prevent infection?
There is one major, number one, all-star intervention to prevent most of this.
Special mass?
Ambulation, ambulation, ambulation. If you aspire to be a post-surgical nurse, which is super fun, that's going to be a part of your being. It will be a part of your cells. Because let's go through these. How is ambulation going to help with pneumonia? Like getting things moving. Because when you're laying in bed, you have stasis fluid. Then you'd have a little bit of nosocomial bacteria sitting in there. But if you're out, respiring, working out, walking on the unit, you're moving all that secretion out. UTI. Yeah, that's right. And do you know that they can pee better when you're ambulating? So do you know that, so what do we call it from a scientific standpoint? Homo
Stasis.
erectus, right? This is us. We are designed, that's what human beings are. We're designed to be standing up. and very little horizontal. All of our sphincters, every body function is designed for this position here. And when you are in a post-surgical situation, you're laying in bed longer than you should be. A couple days, that's abnormal for humans. So this is how those things come about. Yeah, urinary system's gonna work better. How about thrombus, stasis of blood, right? How about small bowels, or does the motility go up when you ambulate? It goes down when you lay in bed. You can die from the bowel obstruction, ischemic up, infection, you know, like UTI, pneumonia is one of the big ones, especially post-op A1. In elderly people, for example, it builds up your immune system. And it also moves fluid from your lungs. You see where I'm going? Things get moving. Things actually mechanically work. Otherwise, everything is stasis, stays there. Hemorrhage, well, that's, you don't want them ambulating when they're hemorrhaging. We're not preventing that with ambulating. That's just the thing that can happen to them, right? Stroke, yeah, so that's thrombus, right? Atelectasis, remember atelectasis? Yes. So, and then of course PE, thrombus, and then, so it is going to be number one, it's going to be ambulation. Okay, now, if it is a lung thing, what are you going to do? Yes, right? And sinus barometer. Are you going to be lazy nurse Debbie, bring in an incentive barometer, put on the bedside table, and not even say anything to the patient? That's a lousy nurse, and I see it. I used to see it all the time. It's like, what are you doing? Why are you even working as a nurse? You're a disservice to your patient because you're not even coaching them. You have to coach them the first time. Remember our concept? So you undo the paper, take the plastic off, get a gloved hand, put your hand over the mouthpiece. Don't put your mouth in the mouthpiece. As if to say, right? Yeah. And then what is it like? And everybody knows, I know this age demographic, and even my demographic. What does this look like? Okay, it's like smoking a bomb. It really is, but I don't say that to my patient. But we know that that's the action that they need. Because are you recruiting alveoli? And for the prevention of pneumonia, are you moving just that air going in there very efficiently is going to help move secretions. It's the secretions that would kill them, both in atelectasis and pneumonia, right? Alveoli stick together. So you need to give them, so you have to coach them. Now, how frequently do they do the incentive spirometer? Yep, a few hours. And don't make them do a specified amount. I tried to see how many times. I was thinking, oh, we're going to do 10 reps. Oh, yeah, no. Because you're going to have a passed out alcoholic patient. They're going to go hyperventilate, you know. No. Do what they can tolerate and have challenged them. See the little cylinder? Now, one thing you can do, and they'll try to impress you too. They'll go like this. They'll go inhale, inhale, inhale. Well, what that does is that little thing goes up, up, up. That is not a good representation of pulmonary function. One big one. Good job. And that's how you have to coach them. One, hold it as long as you can. And then I ask them throughout that coaching, how do you feel? Do you feel lightheaded? Done. Cut it off. That's it. If they only did 3 breaths, it's better than nothing, right? But make sure its frequency is every hour. You can save their life. Oh, and by the way, are they going to have a low-grade temp? The fastest way to bring down that temp is to ambulate and do IS. I swear to you, it works every time unless they have a one. And then the temp's going to continue. But yeah, get rid of that 99.0 and it's going to be done by ambulating and incentive spirometer. You guys will see what I mean. It's really, really cool and remarkable that something as simple as walking and IS will save them. So good. Love it. Okay, I have to go back into my phone because it timed out. And I wanna see what I see. You need to support them with probably some oxygen, but I actually don't have that on here. So, yes, very good. So this is all about prevention, not just typical post-surgical thing. So we have IS, right, with coaching. That's a good nurse. How about turn, cough, and deep breathe? And how do you do that? Make sure they have good bed mobility. Make sure that they cough all that stuff up. And do you coach them with the deep breathing? Yeah, just take some, and how about just some cleansing breaths? And that could be a part of their incentive spirometry. That's actually a separate question or answer, by the way. But turn, cough, deep breathe, and ambulation. Now, what do you do with their diet? Very gradually increase their diet, because you know what happens to a gut if you feed them too heavy of food and too quickly? The gut seizes up. Yeah, I promise, it does. The gut, under anesthesia, under opioids, if the motility is already low and you try to feed it, it just goes. And guess what will happen? It'll start throwing up. Cut and dry. Yeah, you don't want that. Nobody wants that. Because you could get a Mallory Weiss tear out of yours if they're retching like that. That's another hemorrhage problem altogether. And it's uncomfortable to throw up. And plus you don't want them to have this post-surgical complication of a bowel obstruction, because do they have to stay extra days? Yeah, they do. Like it could be even a week to resolve that out. Not good. Would you like to be in the hospital with a garden hose down your throat for a week? That would be hell. That would not even be fun at all. So advance their diet very slowly. Are they gonna beg you for food? Oh yeah. Is every person who walks in that room, are they gonna try to schmooze them to bring them something from the fridge? Somebody's washing the floor, sweeping or something, they're gonna go, patients are gonna go, how are you doing? They're gonna get really schmoozy all of a sudden. And they'll, like heart failure patients will ask for salt. Yes, they do it. And then and they think we're mean. But we have no apologies here because we are saving their life. We're doing what we're supposed to do. But you know what I do? I like to scare people. I like to say, you can shut your gut down and be here for an extra week with a big old tube that we have to stuff down your nose. I make it sound very unattractive, which it is. And then do we have to police people coming in and smuggling food, which happens all the time. We see it. And how do you know that they're smuggling food in?
You can tell. I saw it.
You guys are at the nursing desk, right?
They have like a big purse too.
Yeah, they have this big, and then they'll walk by and they'll look at you and you go, oh, I'm following them in. Open your jacket and you'll see all the watches. You know, like a street corner person. Oh, and then they pull out of that big sack, you know, KFC, Taco Bell, whatever, or even stuff from home. You know, their favorite dish, you know, whatever. Now, what are you going to do at that point? Eat it. That's where it's going to end up probably, at the nurse's desk. So, educate, and do scare the family. I scare family all the time. When I'm giving education before they go home. But in this case, well, you can shut their gut down. And they could not do well. I've heard patients die. And I'll say that. And they have. I'm not lying when I say that. I say I've seen patients die from a bowel obstruction is what we call it. And they're going to extend their hospital stay. So, no, they can't do it. It's not worth it.
The casket size.
Like the tombstone. So, is it clear? Is it ice chips? Clear, full liquid, which is, I think, would be the favorite part because you can eat as much ice cream. Ice cream's good. And then full. I mean regular. I mean that would be either soft diet or regular. So you have to advance them slowly. But how are you as the nurse going to assess that you can advance them? That's bowel sound. Bowel sound. Going from sluggish to hypo to active is what they call that. And our regular bowel sounds. And they have absence of nausea and vomiting with each level that we were. I would never, ever take a chance. There was this one guy, his wife is in the hospital. Oh, he got so pissed off at me for not feeding his wife. I said, wait a minute, you're a nurse. You know better than this. And me and Donna Duran, we noticed that there was an increase in small bowel obstruction. Do you know why? Because the nurses started, the length of hospital stay shortened, but the patients didn't change. They were starting to feed their patients too soon. So I told Judy, my boss, I said, I know what they're doing, they're feeding their patient. We're going against all this evidence base. So then she put out a notice, don't follow the protocol. Yeah, he got really pissed off at me and said, I have no apologies for not feeding your wife, and you should know better. You didn't like me. That's okay. I didn't care. Okay, let's see. So, yeah, so make sure that what we just talked about, those interventions, they're non-negotiable, right? Those are the non-negotiable things to prevent all this. Like, again, it's not the surgery that will kill them. It is the post-surgical complication. Okay. Wait, what is this? Okay, here we go. Are we ready for another question? Speaking of bites, here we go. And you guys may not know this on your own. Black widow spiders. What is one of the major things that they cause?
Inflammation.
Hypertension. Very good. There's some other things. Tachycardia, muscle spasm, abdominal, back, and chest pain, and of course pain at the site. But it's the hypertension that's scary, right? So that's what you want to ask. And then you look at, they say, oh, I have pain, and then you look at it and say, yeah, and sometimes they don't know what bit them. You know how that is, right? But based on those findings in the hypertension, probably a black widow spider. Do we treat the hypertension? Yeah. Do we treat them supportively? Yeah, definitely. Okay, let's move along. And we have got Josephine next. Oh, yeah, this is very good. You're working the ED, and this is a very conceptual question. Many different things can cause swelling in an extremity. Could it be a sprained ankle? Could be a fracture, musculoskeletal trauma. Could be a bite. Could be a snake bite, spider bite. Nevertheless, you know this person coming in, and that foot looks like a big old, twice, 3 times as big as the other one with edema. So you, as the excellent nurse you're going to be, what's the first thing that comes to mind? That you're worried about? Done. End of story. Excellent. Nailed it. Am I going to wait to tell the ED doc? Are you kidding me? That is one of those expedited things that happens immediately. I'm going to go down the hall, I'm going to find he or she, and I'm going to say, please come look at this foot, because I think we're looking at some potential compartment syndrome. But you need evidence to convince that person to come look at it. So what are there some things involved?
TGI.
Wait, TBI?
No.
Oh, what is it? You're right.
I know it's 5 Ps.
Yes, the 5 Ps. So 6. Did we talk about that? Hey, they're all on my level apart.
Pain.
Okay. Pain, paresthesia, paralysis, hopelessness, and poikilothyrmia, which is cool. Yeah. Is it 6? Is that 6? 5 or 6? I'll have to look at that part. I can't remember because that's correct. So now you prove it, right? Take a set of vital signs, prove it to them. If it looks like a duck, squawks like a duck, it is most likely. And that pain that they have, you know why is it so painful? Tissue ischemia. Yeah, tissue ischemia. So what could potentially happen there? What's the problem with that compartment syndrome? Amputation. because the nurse did not report it, take the time to lift up the sheet and look at the extremity.
What are they doing if they have compartments?
What's the treatment for compartment syndrome? Decompressive fasciotomy. And actually, I showed the burn. You can get that with burns too. And there's a beautiful picture of it, which I will show you today. So they cut. And what does it do? It goes, whoa. You want to talk about major dehiscence, but this is a dehiscence in a very good way. And you can tell that this is going to take a lot of wound care. It's going to take a wound back for months, maybe even years if they're diabetic. And guess what? They have an extremity. So the problem with all that edema, it's compressing vessels, causing an outflow, arterial outflow.
This is one that I saw surgery where they did that and then after the cut, I was like,
Oh yeah, it's usually big. Yeah, usually decompressive fasciotomies are big. It could be the whole lateral leg,
Yeah.
all the way. Because if the entire extremity is like that, you have to decompress it. Okay. Save the limb. That's how they do it. Yeah. So please, you guys, recognize the signs and symptoms of compartment syndrome. I'm not going to have the intervention on this test since it's not a nursing intervention, but it's good to know that that's how they treat it. Yeah, and then of course antibiotics could be your role too, pain meds, wound care, they're in constant wound care. Yeah, you're not gonna be doing the first, prescriptions for that at all. Now you may be the one to do the stuff, like the packing and the pudding, because they teach us how to do the wound care. That stuff to me is so boring, I'm sorry. Do we have any wound care people in here? Yeah, do you like wound care? Yeah, some people love it. I mean, passionate about it. Yeah, no. And real great. Yeah, the initial stuff before they degree and do the irrigation and stuff, it's stinky, it's horrible. But you know what? I don't like it. I don't like staying with one patient any longer. I really don't. Unless I'm starting an IV or doing something really fun like that. But wound care to me is like, oh my God, I need to be walking or doing something like that. But no, wound care folks love their job. Plus they have offices and they wear their white lab coat and they come out and they see, it's really very push. They really love it. You could get your certification on that. Yeah. Okay, here we go. Let's talk about some snakes. So what is a viper pit?
What is it called?
Viper pit. What is it? Viper. I think it's viper pit.
Bad situation to fall in.
It's a snake. There's a bad snake. Viper pit. It's a bad snake. Because what does it cause?
Death.
Coagulopathy, hypercoagulopathy. Now, what does that mean once the venom gets in your bloodstream? Death. Secondary to every ounce of your blood clots right up. Do you think a pulmonary embolism is bad? This will kill you. I have a video to show you too. Maybe today, maybe next week. Yeah. So just know it's coagulopathy is what the viper pit or viper pit causes.
Where are those found?
Yeah, I'm not sure. I asked that question. No, that's, is that right?
Yeah. That's what it looks like.
Yeah, the video, it's hard to tell what color. He actually looks kind of brownish. I wonder
There
if
are
they
a
adapt
couple
to our environment. Okay, so let's continue. So no coagulopathy, right? Who's I on? Okay, so the next thing is lightning strike. What is your biggest concern with that? Yeah. Cardiac arrest. It's like shocking a person who does not need to be shocked. And you know, and I confirmed this today because this goes back and forth. Do you perform CPR on a person who has a pulse? No. Could you cause an arrhythmia? And the reason I say that, there was a time when I was still practicing that they would, like if you had a weak pulse, they would have you still do But then they found out, no, it's not good. So the outcomes were again proven to be not so great. So follow your hospital policy and procedure, because that could change next week. It's been pretty consistent for a while. Okay, so very good. Okay, Tijuana.
Can you repeat that?
Yes, lightning strike, cardiac arrest, and arrhythmias. Shocking. You don't want to shock somebody who does not need to be shocked, right? Yeah. And the other thing, could they get an electrical burn throughout their body? It's weird. If you know anybody, I had a friend he was working in the field. He got electrical current go through his body, and then it went through his arm, and he lost like 3 fingers. It was not cool. Luckily, he was cute. Hello. Oh, I do have a good one for you. This is so great. Oncology patient. So, what type of isolation do you put them in? Neutropenic, and what exactly does that mean? Yeah. Oh, what somebody said earlier, what she said was new kids or something was really cute. So, germ factories. I think she said fresh kids, I don't know. That's what she said, it was hilarious. Yeah, no fresh kids, she did, it was hilarious. Yeah. Okay, and we've already done the radiation thing, right? Okay, and one more question for you. So private room, neutropenic precautions, and your entire shift, you're gonna be assessing for what? Myelo? Exactly, and what does that mean? Low. Reds, white, and platelets, done, end of story. Because we know if you have low red cells, anemia, can you actually die from anemia? Yeah. Your organs can become so ischemic, almost like shock, right? To where they stop working. Need oxygen for life. And then of course, white cells, low immunity, sepsis, and then platelets would be bleeding. Anything thrombocytopenic is bleeding. You have a couple different types of thrombocytopenia, so always look for bleeding in your answer. In ATI, the boards, whatever. Good job. We've revisited, you guys have to know that. Can you tell? We've had that on every single test. So that's going to be a freebie for you, but that's okay. It's worth running that through out, because it's so important. Because if you ever work chemotherapy units or oncology units, that's what they die from. They die from the hemodynamics, they die from sepsis, and you can't allow that to happen. You have to be a good nurse. Okay, Adriana. Oh, I love this part. What are the 3 different types of shock? Yes.
Or obstructive.
And you said it. Cardiogenic.
Oh.
Yeah. So on your study focus, I have obstructive, and then under obstructive, I have cardiogenic. What we're going to do this time, we're going to separate those. So cardiogenic at one time was considered an obstructive type of shock, but what I'm seeing is they're separating them now. I'm separating yeah. So it's like obstructive, and then you have cardiogenic, so no. So please, on your study focus, put that as a separate category. So Elizabeth, so give us, how can you describe cardiogenic, or rather you can give us the causes of cardiogenic shock? Make it easy. And somebody in the first class, they said pump failure, right? So literature will say pump failure, but what causes that pump failure? Lots of. Oh, MI, good. What else? Cardiomyopathies. Yeah, so, valvular issues, go ahead.
But, okay, could compartment syndrome?
No, no. Cause you can't have compartment syndrome in the heart, right? So valves, MI, cardiomyopathy, what was it? Heart failure, yes, big one. Now tamponade, according to ATI, is considered obstructive. So take a note of that, please. Tamponade is obstructive. You know why? Because it's outside the heart. I know. That's the only one that's a little bit, At one time that was cardiogenic, or maybe it's always been obstructive with the cardiogenic version, but it is obstructive.
What about arthritis? Can I get the table? Yeah, it's confused.
Look it up in ATI. Yeah, it's right there. Yeah, look it up in ATI. Oh, is it on there? Name the obstructive ones, because I think I named this last week, right?
It says blockage of great vessels
Yep.
or the heart itself. Examples: PE, tension, pneumothorax, cardiac tamponade.
Exactly, and that's where I'm gonna get my answers right there. That's it, love it. And then, so pure, and that's why I say pure cardiac causes, like valves, anything where you have damage myocardium, like cardiomyopathy, MI, and then of course, heart failure caused by valves, anything in the heart. So think about the pericardial sac is on the outside, just like that tension pneumo, pressing those great vessels, pulmonary embolus. Now that came from someplace outside the heart, but ended up in the heart, right? It's not the heart muscle. See where I'm going? Yeah, so think heart muscle damage versus other causes like compression of vessels. Those would be your obstructive causes. So yeah, just look it up in your book, and make I would suggest you make your own graph, right? Like that we talked about. Okay, are you ready, Noreen? I think I have a really good one for you. So distributive shock. What are the shocks that go under that category?
Did you hear me?
No, I did not.
Oh.
No, I can't, because this is on and I'm still gonna have this. Okay, so septic, hypovolemic, they might put that, I kind of think they have hypovolemic as its own thing, but it kind of is a distributive sort of shock. So I'm gonna do that. So we have septic, hypovolemic, anaphylactic, and neurogenic, right? On your test, what I'd like to do, I might do this. I think I've already tested you on it. So what's the mechanism of neurogenic shock? Loss of sympathetic tone. Good. For hypovolemic shock, what's the problem with that one? There's not enough circulating volume related to, guess what? One word, matchy, losses. Losses. And what are we losing? Here, and bleeding. And burns. Remember what happens with burns? And or ascites, maldistributed. See where they get the word? Maldistribution of fluid. It's distributed shock. And they describe it as having that dilatory component. So do you have vasodilation and systemic inflammatory septic shock? You sure do. Do you have it in neurogenic shock? Loss of sympathetic tone, is that gonna cause you to vasodilate? Yep. And are you gonna get vasodilation in anaphylactic shock? All three of those are distributed. Now let's go through the treatments for each of those. So let's go to, oh my God, no. Not Laura. Oh, I've known her name the whole time. Kara.
No.
What is Sarah? Kara. That's close. See, I'm pretty lame with that. Okay, so how are you gonna treat hypovolemic shock? Easy.
So pressors, fluids.
Fluids first, right, and then pressors if that doesn't work. How about your anaphylaxis? Epi, which will do broncho and vasoconstriction. Yep, very good. What about the neurogenic shock?
Oxygen, fluids, pressors.
Yep, oxygen and fluid. And then when you give that pressor, is that gonna help that bradycardia? Isn't neurogenic very, very unique in the fact that they're bradycardic versus tachycardic? Whenever you have dilution, you typically get tachycardic, but with neurogenic shock, without catecholamines, are gonna be bradycardic. But if you have to give them a pressor, is that gonna crank up the pulse? Yeah. And then septic shock. I'm gonna move along, very good by the way. So fluids and, oh, and she said oxygen too. Why oxygen? One word,
Perfusion?
tissue, ischemia, right? Secondary to hypoperfusion. Because isn't that what shock is? It's hypoperfusion? So we're gonna have to, so support them with oxygen, but really, are you gonna take care of the hemodynamics first? If I have like a blood pressure, I'm looking at my numbers. I'm looking at a 70 over 30 and they're running 140 on their pulse. I said, we need fluid in here. We give them a liter. They don't respond, let's get some levofed in there. Kayla, what is your question here for you? So, what was it? So we have the epi, we have the fluids, we have, the other thing too, for the distributive shocks, is there anything else you can give them beside, heart-wise, besides the pressor to increase cardiac output?
That's it.
Yeah, so think about increased cardiac output. Are you going to, besides giving them pressors, to increase? Is there another pressor that you could give them? And maybe you could just give them one. Dobutamine, you said that. Yeah, you're right. Dobutamine is they call it, it's inotrope. So it's inotrope, so squeeze, squeeze, squeeze. If they need extra support, right? Oh,
Why not?
it's 50. Oh, that's for symptomatic bradycardia. Which, one of the jobs? Oh, neurogenic? Oh, it's good to know. I wonder if ATI says that. Okay, let's take a break.